Meet Sarah, a 16-year-old unmarried pregnant teenage girl. If only Sarah knew how to say no. Let's go and help Sarah from the beginning. 9 months ago, like any other teenager, Sarah loved to socialize and hang out with friends. Because of her interesting character, no doubt many became interested in Sarah. Some of them were sincere in becoming friends. And there were also those who wanted to take advantage of her. Most of them were boys, but there were also girls. Some of them seduced Sarah, beckoning her, and some were very frank with their intention. Everything is geared towards sexual activity, and Sarah began to become confused. Do you know the risks that Sarah might face if she is taken in with all these temptations? First, she could be admitted into a rehabilitation center. Second, the risk of pregnancy would be 4 times bigger. And third, she could also be exposed to HIV and will be at risk to other sexually transmitted diseases such as syphilis and gonorrhea. Sarah should refrain herself from giving in. Therefore, she needs to know about the 3 levels of risky behaviors that must be avoided, which are no risk, which is a solo act, such as fantasizing and masturbating where it does not pose any risk of HIV. Low risk act, such as French kissing and masturbating each other. High risk act, such as vaginal sex, anal, and oral. We all know that big things are generated from small things. If Sarah had known about all levels of risky behaviors, she will surely avoid them, even if it is a no-risk act, because it will only lead to a high-risk act, which is very risky, such as sexual activities outside of wedlock. According to various researches, the involvement of adolescents in sexual activity outside of wedlock in Malaysia is increasing year by year. Sarah should be aware of this, so she does not become part of the statistic of teenage pregnancy cases. Did you know that on average, there are 18,000 new cases of teenage pregnancies registered with the Ministry of Health facilities every year from 2011 to 2013? Yes, this is equal to the number of students in 18 schools. And it continues to grow year by year. Sarah does not have to repeat their mistake. Sarah now bears the knowledge of the risks, as well as all the risky behaviors. Sarah should have the courage to reject, resist, and insist to say no to risky acts. Meet Sarah, a 16-year-old girl responsible for all the actions that she chose. This message is brought to you by National Population and the Family Development Board, LPPKN, and the United Nations Population Fund, UNFPA. For inquiries, advice, and assistance, please contact 03-2693-7555 and the care line 15999 or visit our website www.lppkn.gov.my.
The Ministry of Women, Family and Community Development, through the National Population and Family Development Board, has developed the Malaysian Family Wellbeing Index 2016, or FWBI 2016, to measure the well-being of families in Malaysia. The main purpose of this index is to help family-related policymakers and program planners develop appropriate and holistic intervention programs according to each domain and indicator. The measurement of family well-being is done through the implementation of the Malaysian Family Well-being Index Study 2016. A total of 8,254 living quarters and 3,878 Malaysian citizens respondents were interviewed. 2,008 of the respondents were fathers, and 1,870 were mothers of children aged between 3 and 24 years old. FWBI 2016 has 8 domains which consist of 23 indicators. Family Relationship Domain, Family Economy Domain, Family Health Domain, Family Safety Domain, Family and Community Engagement Domain, Family, Role of Religion and Spirituality Practices Domain, Housing and Environment Domain, Family and Communication Technology Domain. The FWBI 2016 score was divided into 3 levels, which are high 8 to 10, moderate 5 to 7, and low 0 to 4. For the overall FWBI 2016, Malaysia is at a moderate level with a score of 7.33 out of the total score of 10. From the 8 domains listed, the Family, Role of Religion and Spirituality Practices domain recorded the highest score of 8.04. It is followed by Family Safety domain 7.96, Family Relationship domain 7.90, Family and Community Engagement domain 7.84, Family Health domain 7.18, Family Economy domain 7.05, Family and Communication Technology domain 6.38, and Housing and Environment domain 6.24. Comparison of the FWBI 2016 score by state showed that Malacca has the highest score of 8.28. It is followed by states Perak 7.71, Johor 7.61, Terengganu 7.56, Selangor 7.33, Kedah 7.32, Kelantan 7.32, Penang 7.31, Federal Territory 7.15, Sabah 7.10, Sarawak 7.09, Perlis 6.97, Negeri Sembilan 6.78, and Pahang 6.72. Among the suggestions to improve the well-being of the family is to enhance the organization of programs such as programs to promote recycling practices as well as improve public amenities, especially in the rural areas. Programs regarding parents' knowledge and skills in monitoring the use of communication technologies among children. Economic development programs among low-income families. Program that empowers healthy lifestyle practices and physical activities among families. Programs on knowledge and social skills through strengthening emotional bonds as well as enhancing social support at community level. Improve parenting skills programs, especially in communication skills with children, either verbal or non-verbal. Programs in the form of educational campaigns and awareness of family safety at home. Spiritual programs through religious practices and beliefs at family and community level. For more information on FWBI 2016, please visit www.lppkn.gov.my.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and a very good morning. Mr. Najib Asifi, UNFPA representative for Malaysia and country director for Thailand, Yang Berusaha Tuan Haji Abdul Syukur bin Abdullah, Director General National Population and Family Development Board Malaysia, Dr. Rintaro Mori, Regional Advisor, UNFPA Asia Pacific Regional Office, Yang Berusaha Associate Professor Insinyur Dr. Siti Anum Ahmad, Director, Malaysian Research Institute on Aging, University Putra Malaysia, Country Directors, representatives from various ministries, universities, departments, agencies and non-governmental organizations, our invited speakers, distinguished guests, ladies and gentlemen. I am Associate Professor Dr. Hayati Kadir Shahar. It is my pleasure to be the MC today. On behalf of the organizer, Malaysian Research Institute on Aging, MyAging, University Putra Malaysia, and the National Population and Family Development Board, we wish to extend our warm welcome or selamat datang to the Conference on Research on Aging in the Pandemic Age, Regional South-South Perspectives. Ladies and gentlemen, the COVID-19 pandemic has caused untold fear and suffering for older adults across the world. It has brought unprecedented challenges and disproportionate significant threat onto older adults' lives, relationships, and well-being. The risk of COVID-19 is higher for older adults with underlying multimorbidity. To date, many studies have been conducted in several Asian member states, comprising issues and challenges of aging, such as health, housing, financial support, and care for older persons. Based on these in-country research findings, policies and programs have been developed to harness the energies of older persons, increase their productivity, and integrate them into the nation's development process. However, little research is known about elderly people's responses to the pandemic, particularly among South-South countries. In light of this, today's conference will therefore provide a platform to exchange knowledge, experiences, and research that has been done pertaining to aging in today's pandemic age for comparative perspective. To begin this conference, we are pleased to have Yang Berusaha Tuan Haji Abdul Syukur bin Abdullah, Director General National Population and Family Development Board Malaysia, NPFDB, to deliver his opening statement.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and good morning everyone. Yang berbahagia Profesor Datuk Dr. Tunku Aizan Hamid, Malaysian Research Institute on Aging, MyAging, University of Putra Malaysia, Country Director from Malaysia for ASEAN Wide Research Networking on Aging, Professor Yasuhiko Saito, aging expert from University Research Center, Nihon University, Japan, Dr. Rintaro Mori, Technical Advisor, United Nations Population Fund, Asia Pacific Regional Office, Mr. Najib Asifi, Country Directors from the ASEAN member state, respective presenters from various countries, officials and representatives from relevant government agencies and universities. Ladies and gentlemen, it gives me great pleasure to welcome each of you virtually at today's conference on research on aging in the pandemic age, regional South-South perspectives in conjunction with the third regional workshop, Research Protocol on Aging towards the establishment of ASEAN-wide research networking on aging. This conference is a follow-up to the regional meeting of country directors and the regional workshop which was held in 2019, coordinated by the Ministry of Women, Family and Community Development Malaysia, National Population and Family Development Board, and Malaysian Research Institute on Aging, University of Putra, Malaysia. A special thanks to Japan ASEAN Cooperation JAIF for funding this project. Ladies and gentlemen, COVID-19 is causing major social and economic disruption which is evolving rapid around the world. To date, the highly infectious virus is continuing its spread across the world with more than 60 million confirmed cases in 190 countries and about 1.5 million deaths. Although all age groups are at risk of contracting COVID-19, older people face significant risk of developing severe illness if they contract the disease due to physiological changes that come with aging and potential underlying health conditions. What worries us more, the risk they might be infected was significantly higher for older adults with underlying multimorbidity who live in long-term care facilities, aged care homes, nursing homes, and similar. COVID-19 has impacted their life very much, with 8 out of 10 COVID-19 deaths reported in the US have been in adults 65 years old and older. To date, many researches has been conducted in most of ASEAN countries comprising issues and challenges of aging such as health, housing, financial support, and care for older persons. However, little research is known about elderly people's responses to the pandemic, particularly among South-South countries. This conference will therefore provide a platform to exchange knowledge, experiences, and research pertaining to aging in today's pandemic age for comparative perspective. At the international level, population aging has been featured prominently since the 1994 International Conference on Population and Development, which recognized the economic and social impact of population aging in all societies. This is evidenced by the high-level political commitment of the ASEAN leaders reflected in the Kuala Lumpur Declaration on Active Aging, Empowering Older Persons in ASEAN 2015. The declaration provides that preparing for aging is a shared responsibility requiring intergenerational solidarity and a community-based, need-based, and life cycle approach. Implementing the Kuala Lumpur Declaration on Aging will also contribute to the implementation of the 2030 Agenda for Sustainable Development, as well as achieving the ASEAN Community Vision 2025. Ladies and gentlemen, ASEAN member states are approaching the final stage of the demographic transition and moving towards into the aging society. In some ASEAN countries, studies has been conducted to identify major challenges and to develop workable and successful policies and programs to harness the energies of older people, increase their productivity, and integrate senior citizens into the development process. However, due to constraint of resources, research findings and the best practices are not widely shared among the ASEAN member countries. Furthermore, limited networking among researchers and lack of standardization in research protocols such as methodology, common definition, and terminology make it rather difficult to do cross-country comparisons among ASEAN member states, thus hampering the ability of national governments to formulate effective policies, resource allocation, and program development. As ASEAN region shares a similar heritage of diversity in culture, religion, and social historical ties. Commonality in research and sharing of information will be highly beneficial to policymakers and program planners. Thus, there is an urgent need to establish a regional platform of standardized research agenda among ASEAN countries to share findings, best practices, and research protocol to enable national governments to formulate effective policy, resource allocation, and program development. With that objective in mind, I hereby officiate the opening of the Conference on Research on Aging in the Pandemic Age Regional South-South Perspective in conjunction with the third regional workshop, Research Protocol on Aging towards the establishment of ASEAN-wide research networking on aging. Thank you very much, and I wish you all a fruitful conference.
Thank you, Tuan Haji Abdul Shukur, for the opening statement. Now, I would like to welcome Mr. Najib Asifi, UNFPA representative for Malaysia and country director for Thailand, to deliver his welcoming statement.
Assalamu alaikum wa rahmatullahi wa barakatuh. Mr. Abdul Shukur Abdullah, Director General, National Population and Family Development Board, Malaysia. Associated Professor Dr. Siti Anam Ahmad, Director, Malaysia Research Institute of Aging, My Aging University, Putra, Malaysia. My colleague, Dr. Rintaro Mori, Regional Advisor, Population Aging and Sustainable Development, UNFPA Asia Pacific Regional Office, Bangkok. Our esteemed speakers from the region, Vietnam, Thailand, Malaysia, Brunei Darussalam, Singapore, Indonesia, Philippines, Myanmar, and Japan. Distinguished guests, ladies and gentlemen, it is my pleasure to welcome you all to this conference on research on aging in the pandemic age. It is an honor to join you today at this important event, promoting South-South cooperation in our pursuit of sustained economic development for national and collective self-reliance, particularly during COVID-19 pandemic recovery area that has impacted us all, our families, and our communities. Ladies and gentlemen, the idea of South-South cooperation in UNFPA takes into consideration country-specific contexts and implemented in accordance with the national priorities, aspirations, and UNFPA's scope, and particular ownership-oriented models for developing and implementing collaborative initiatives among developing countries. It fosters cooperation between national institutions, mainly governmental, but also broad alliances involving non-governmental organizations with potential comparative advantage in the global south. Some countries have similar environments, face common problems, and seek to achieve common goals, while some countries that are further advanced in their demographic transition and development have important experiences to share with other developing countries in the formulation of policies and programs to provide support and accelerate development. The increase in South-South trade shows that businesses among developing countries have been increasing, as well as agreements, connection among institutions, and the sharing of knowledge and capital. However, despite economic growth in achievement and development, not all countries from the global south have experienced equal gains in areas related to population and development. Disparities exist not only across regions, but also within countries. This rapid expansion of economic relations and trade among global south countries motivate us to address common challenges and share potential solutions. In this context, it is an opportunity for using the already established Southern networks to address the institutional and capacity gaps among countries related to population and development, particularly on the need for us to respond to the needs of older persons in light of the current pandemic. This is also part of the unfinished ICPD agenda. South-South cooperation can be used to tackle the most critical global disparities among developing countries. Today, most developed and advanced developing countries will see the window of opportunity to realize a demographic dividend close within the next few years, while a considerable number of less developed countries will have this window open or remain open for the next few years. There are many opportunities for South-South cooperation. Considering the different stages in demographic transition, there is a great scope for countries that are among advanced to share their experiences with the countries that are less advanced and to help the latter realize economic gains that come with the transition, while addressing challenges that this transition brings, such as population aging. As developed countries like Japan and even some developing countries like Croatia have the highest share of older persons with 28% and 20% respectively, while other developing countries such as Taiwan see the most rapid rates of population aging at 19.9 percentage point increase. There is considerable scope for countries to share their experiences with respect to policies and programs that address low fertility and population aging. Ladies and gentlemen, the COVID-19 pandemic had caused untold fear and suffering for older persons around the world. As of 26 April, the fatality rates due to the virus for those over 80 years of age are 5 times the global average. As the virus spread rapidly to developing countries with likely overwhelming health and social protection systems, the mortality rate for older persons could climb even higher. Less visible, but no less worrisome, is the broader effects, such as the health care denied for conditions unrelated to COVID-19, neglect and abuse in institutions and care facilities, an increase in poverty and unemployment, the demographic impact on well-being and mental health, and the trauma of stigma and discrimination. Efforts to protect older persons should not overlook the many variations within this category. Their incredible resilience and positivity in the multiple roles they have in society, including as caregivers, volunteers, and community leaders. We must see the full diversity of people within the older persons category. Women, for instance, are overrepresented among both older persons and among the paid and unpaid care workers who look after them. We must also recognize the importance of contribution of older persons to the crisis response, including as health workers and caregivers. Older women often provide care for older relatives, increasing their risk to infection. Each of us, state, businesses, international organizations, companies, communities, friends, and family, need to step up our effort to support older persons. We must do everything possible to preserve their rights and dignity at all times. In the Asia Pacific, while COVID-19 has reached only a small fraction of older persons, their risk is closely tied to location. Older persons in Thailand, for example, currently have little or no risk of contracting COVID-19, while those living in India, particularly in the outbreak areas, have much higher exposure. Mortality from COVID-19 increases with age, but younger age groups are a large proportion of deaths in middle-income countries. Older persons living in large households are at increased risk of infection. Compared to Europe and North America, household sizes in Asia and Pacific are larger, on average bringing greater risks within household transmission. These households face added risk due to the closing and opening of schools in areas where an outbreak is occurring. During the Nairobi summit on ICPD 25, which was held last year, Malaysia in its commitment statement recognized that it will be an aged nation by year 2030, and that the tempo of aging will be accelerating, increasing the dependent population that will need to be supported by economically active young people. Malaysia stated that the formulation of its national population policy framework will harness the demographic dividend and address the needs of an aging population. The efforts toward this end is even more crucial now as we respond to the pandemic. With the current higher global profile of older persons because of their risk from COVID-19, more action directly targeted at older persons are needed in national response plans. Among health and care responses, the most universal government measures are those to prevent transmission of COVID-19 and to protect older persons along with the whole population. Just a handful of countries in the region have introduced various forms of support for health insurance as part of their COVID-19 response, such as funding employee contribution, reducing premium, or covering COVID-19 related expenses. Efforts are being made to address the risk and needs of those who receive care support, though mainly for minority receiving formal care services. Governments with established formal long-term care systems have established guidelines and support measures to mitigate the spread of COVID-19 within care homes to support continuity of services, even with physical distancing in place. However, more government or private support is required for the vast majority of older persons with care needs and their family cares. Social protection has been an integral component of almost every government's early COVID-19 response. In Asia Pacific, social assistance constitutes 75% of all responses, and about half of those are cash transfers. COVID-19 era, cash transfers are relatively generous, especially in the context to pre-COVID-19 social protection for older persons. Most of the emergency cash transfers are for short duration and without policy changes, despite the deepening economic crisis. Only several new policy announcements have been made in Asia Pacific in June and July. Despite substantial population aging, only 13 Asian Pacific countries have so far adopted pension system for older persons as a COVID-19 response. The pandemic has demonstrated the value of universal social protection systems. Countries with effective and comprehensive social protection systems are likely to have institutional capacities and systems in place to scale up programs relatively quickly. On the other hand, countries that lack robust systems may need to develop their policies and intervention in an ad hoc way and build institutional capacity under difficult circumstances. That approach may lead to delayed and ineffective responses. In recognition that COVID-19 crisis calls for rapid progress towards universal social protection has been shared even by the World Bank and IMF, institutions often associated with advocating for narrow poverty targeting of benefits. In order to move towards a better future for all generations, one of the key recommendations is to gather evidence about older persons' situations in the pandemic. This includes surveys specifically targeted at older persons, but even more productive might be the inclusion of older persons in larger population-wide surveys. This will facilitate generating important medium to long-term recommendations that could be transformational if adopted. For example, they include tackling fundamental social threats, including inequality and sustainable use of planet resources. These, in turn, could facilitate reforms that improve the situation of older persons, such as strengthening inclusive national system for social protection, health care, and long-term care, and reducing climate-related threats to health and livelihood. Ladies and gentlemen, on behalf of UNFPA, I take this opportunity to congratulate my agent in LPPKN for organizing this important conference today. We need South-South cooperation that generate synergies for the ICPD and SDGs, making the world a better place for all, including the older persons. There is extensive global speculation on whether the post-COVID world will be worse or represent an opportunity to build back better and tackle big challenges. Whatever their outlook, many agree that business as usual is not the goal, especially given alarming risk to the Sustainable Development Goals. I wish to thank you for your attention, and I hope that you will have a productive conference in the next 2 days. Thank you very much.
Thank you, Mr. Najib Asifi, for the wonderful welcoming statement. Distinguished guests, ladies and gentlemen, before we begin the keynote address, allow me to introduce our speaker. Dr. Rintaro Mori is the Regional Advisor on Population Aging and Sustainable Development at UNFPA Asia Pacific Office. After pediatric training in Japan, he practiced in Australia, Nepal, and the UK as a senior pediatrician and studied epidemiology at the London School of Hygiene and Tropical Medicine. He has also actively been involved in research and aid works in Madagascar, Bangladesh, and Mongolia, as well as research in health systems, women's and children's health at both national and global level. Dr. Rintaro was appointed as Director of Department of Health Policy at the National Center for Child Health and Development and Professor in health policy for families and children at Kyoto University. He pursued his research on the life course approach to achieve sustainable social and healthcare system in the context of population aging from 2012 until 2018. He is also the editor of Cochrane Pregnancy and Childbirth and has authored over 300 scientific publications. Ladies and gentlemen, we are honored to call upon our distinguished speaker, Dr. Rintaro Mori, to deliver his keynote address entitled Ideas for Asian Collaborative Research Amid the COVID-19 Pandemic and Rapid Aging Population.
Thank you very much for the introduction. And I think good morning, everyone. It's a great honor to actually sort of provide this speech today. But I think I really appreciate this opportunity, not only actually providing the opportunity to talk about actually our ideas, but also this is very important, really critical to have a collaborations and the conversations on each actually the research idea or what has been done to actually reduce the waste of the research as well, which I'm actually going to cover later. UNFPA, the Asia Pacific Regional Office, actually will be publishing the 2 reports next week. One report is around situations of the older persons by the COVID-19. And I think briefly I can mention that they probably or you know that there is a direct actually impact for the COVID-19 on the older persons, on the health of the older person, directly mortality, morbidities. But also, there are 3 aspects of the indirect actual impact. As the 3 one is a healthcare access, the second is a income security, and the third is more a mental health or relationship pillar or isolation. But population aging is not just only for the older persons, as you can see from my career. The population aging in this region, particularly actually driven by the rapid fertility decline. Another report we are going to publish quite soon is actually COVID-19 impacts on the fertility behavior. The COVID-19 impact has a significant impact on the fertility behavior and probably fertility rate in many countries. But the impact seems to be quite different between high and low middle income countries. The pathway to the impact have 3. One is access to the family planning, and the second is actually the division of the domestic labor has been changed because of the COVID-19 lockdown. And the third is economic recession and the uncertainty around. So certainly it is a very important agenda. Sorry, I think if you could actually put my slide, I think we're going to use that slide now. Thank you very much. So I think I'm going to talk about actually the ideas on ASEAN collaborative research amid COVID-19 pandemic and a rapid aging population. Next slide, please. The issues I want to cover has this research waste. I don't want to actually discourage actually doing the research, but if we do so, we actually need to think about the wise use of money for our actual purpose. The second is actually like to encourage life cycle approach. We're actually looking at population aging or aging, not actually only for the older person. Of course, care for the older person is critical, but aging actually starts from the conception. So we actually need to think about or change the mindset of it. And the third is not only because of the COVID-19, but I think the whole of the world is facing the major transformation. That's because of the mega trends, including population aging. So how are we actually going to address it? That's something we need to think about it. Then actually going to cover the research idea. That's my own idea, so you don't need to listen to me. But I think if it's going to be helpful in some way, I really appreciate it. Next slide, please. my actually sort of the supervisor, Ian Chalmers, actually said that the progress has been made towards reducing the 85% of the wasted efforts in the medical research. 85%. The huge amounts of the money misspent and harm caused for the patients, but there is a still long way to go. So huge actually amount of money and the way efforts has been wasted. We actually realize it now. Next slide, please. I'm going to show you the one example. Well, I think it's a bit of a sort of the childcare and the pediatrics. We have a long standing of the research in the global sort of arena, so please bear with me for a while. There's a very famous book on the baby and the childcare. It's about how going to nurture the children, and it's actually written by the pediatrician called Dr. Benjamin Spock. I'm a pediatrician too, and many people has been reading it and the guiding. This is actually the guiding through the whole of the child care for whole many countries. So next slide, please. And one of the conditions in the book talked about the condition called SIDS, Sudden Infant Death Syndrome. You know, in the infant stage, not some, but rarely, but though, occasionally the parents of the baby found the baby is dead in the bed without any reason. We call it a sudden infant death syndrome. It's actually said to be there's so many multiple causes. But what we know is, as a public health actually practitioner, is there are major risk factors. And one of the risk factors is putting babies on the prone position. Baby put on a tummy is actually risk factors. And actually everybody knows it now. But the research I'm going to talk about this here is actually the relationship. The study is actually looking at association between the baby put on tummy, prone positions, and the sort of the incidence of the SIDS. So that's a scientific evidence to support policy interventions. And what we did is, what Ian Chalmers did is actually, this is a systematic review. So we actually systematically to identify papers looking at these associations. And the first paper we actually sort of they come up with is in the very old. You can see that from this sort of the figure. You might not see it actually in the detail, but the paper published in 1965 by Carpenter et al. And you can see that on the right-hand side, it's odds ratio. The circular is the odds ratio, and the line, the horizontal line is a 95% confidence interval. It's covering 1, means that there is no actually statistical significant difference on the association, but the trend sort of towards there is a positive association, and that will be put on prone and SIDS. And the second paper is the paper by Frogat in 1970. Similar result. And the second line is not about sort of the papers by Frogat. It's a combination, combining the two results. And the third one is a Tonkin in 1970. So the combination of the first 3 papers showed significant difference on association. So by the end of 1970, the world knew that there is association. Next slide, please. However, the policy interventions were so much delayed. You can see that I've selected several countries there who actually started the national public health campaign to prevent SIDS. Starting from Australia, followed by UK, the US, and Japan. You can see that as soon as actually they started the intervention, the reduction of the SIDS, the baby's death was dropped down. So it worked. Next slide, please. But the year they started the intervention was 1990. You can see that 20 years it took from actually bridging from the scientific world to the policy field. But I think the more shocking thing is you can see that after the 1970, so many studies been done to repeat manner, to just sort of the same study design being repeated and repeated again. Well, I think sometimes it's actually quite important to see that, for example, ethnic difference and any sort of the subpopulation difference. But you can see that all studies are trying to address the same questions has been done. We call it waste, research waste. So next slide, please. So what actually I really want to emphasize, actually, sort of the first part of my talk is we really want to ensure that when we actually propose research, the research needs to be fit for the purpose, in a way to focus research questions, and we actually ensure that any existing sort of the research being actually sort of the existing there, by conducting systematic review or the scoping review, whatever you call it, systematic review the existing data or evidence to say, justify your research. Third is a high quality. Of course, I mean, there is always a money, and the problem is money or the funding or the access to the sort of the people's data. So huge limitation, I know that. However, I think within the sort of the available sort of resources, we actually need to maximize the sort of the highest quality of the research. That's what we could do. Otherwise, your money, your fund, your effort, the patients or the people's efforts to participate in research is going to be wasted. And I think so if it's, I mean, even actually if it's a low quality studies, it's going to mislead the conclusions. And the last, at least, I think the Secretary General, the Director General actually mentioned that standardization, the comparability, particularly ASEAN, you're really active on the collaborative research. This is very important. I really appreciate and respect that. So standardization is very important for them. Next slide, please. The second part I'd like to emphasize is a life cycle approach. I mentioned that the population aging, not just for the older persons. I'm going to read through that because I think I developed this sentence with this Professor Chitwat Gitebaston, an integrated inclusive framework based upon the use in climate science, adaptation, mitigation, and resilience. All you know that, adaptation, mitigation, resilience. To make that comprises we need and start to get there. So we actually sort of advocating to use that framework, adaptation, mitigation, and resilience, to be applied for the population aging as well. Okay, I'm not read all through, but if you could have a look at the table here and below. For the mitigation, we actually need to include well-being for those in need today, probably for the older person specifically, as well as not only for the older person, everybody. Because if you pick up anyone, any older person very different. There's some of the older persons quite powerful and sort of the rich, many of the sort of the richest of the rich are actually sort of people in Asia, the older persons, and where some of the older persons poor, living the poverty, suffered because not only the poverty but because of the aging related to disabilities. So we actually need to think about sort of or get away from just sort of the aging framework, see how the whole of people, all the persons. The second is mitigation. So we actually sort of think about improving the current and the future condition of people who already have many aspects of their life course in trend. What we imply to say is the key issues for the healthy aging, we know that is a non-communicable diseases, right? And including mental health. So the life course approach means that, let's think about the population aging. People think that population aging is like this. There's a sort of a bunch of young people. And I think the year by year, the proportion of the older persons being increased. But is that really true? It's not. Because the people it's getting healthier. The 60 years old 20 years ago is very different from the 60 years old now. So next slide, please. rather than just sort of increase the proportion of the older persons, it is actually means that extending whole of the life cycle, whole of the life course, including actually the duration of the childhood is being extended, duration of the older age, later stage is also extended, right? So the whole of lifespan has been extended. However, there is a problem here. Next slide, please. Because of the social rigid system, the social system doesn't meet the needs of the current populations or the future populations. So you can see the black lines. It's a rigid social system. I mean, not only just I'm talking about actually retirement age, but it's the work-life balance and the support for the childbearing and the educational system. Actually, we need to think about the freeing a lifelong flexible choice of education, childbearing, work, and care, unable actually to meet the needs of the current and the future population. Next slide, please.
In recent decades, we have seen major improvements in nutrition, education, healthcare, and sanitation worldwide. As a result, we are living longer than ever before. This social transformation is a triumph of development. Asia and the Pacific is a diverse region, and how people age is often dependent on factors such as wealth, ethnicity, social standing, and education. The effects of gender discrimination throughout life, including fewer rights, less access to education and health services, as well as lower earning capacity, leave women even more disadvantaged in an aging society. To ensure that progress is inclusive for all and to take advantage of the opportunities an aging population offers, governments must incorporate aging issues into national development and health plans. Otherwise, an aging population places an unsustainable strain on financial and healthcare systems. If policies address the whole life cycle, healthy older people can contribute financially by working and socially by volunteering and caring for family members. A life cycle approach to aging offers an opportunity to benefit all in society. This means making investments and formulating legislation in terms of income security, healthcare and pensions across the life cycle, and considering all life's milestones from birth through to childhood, education, working years and beyond. Prenatal care reduces infant and maternal mortality and promotes longer-term health. CSE, or Comprehensive Sexuality Education, helps prevent unintended pregnancy and STIs and gives girls control of reproductive health. Elimination of harmful practices prevents forced or early marriage and allows girls to reach their potential. Intergenerational relationships allow flexibility as different generations play a part in family life. Promote social inclusion to meet the health needs of older people and include them in decision-making. Tackling ageism helps fight discrimination and social prejudice. This life cycle approach needs to be ongoing and ingrained in society through the development of sustainable and equitable systems of health and social care, backed by data measurement and research. Let's look at the milestones facing two women born on the same day in Asia Pacific. A is from a poor rural family in a low-income country, and B is born to a professional urban family in an upper middle-income country. Both girls have the same potential, but are on very different life paths. B's birth in a hospital is safe. Her mother had a midwife who supports her with advice on breastfeeding and childhood nutrition. Born at home in her village, A has no access to maternity services. Mothers and children like her are vulnerable to complications during pregnancy, childbirth, and the postnatal period. Support from public health services, health checks, and full vaccinations help B grow into a healthy toddler. Children in low-income countries like A's are likely to have low birth weight and to be malnourished. Disadvantaged nutritional and social environments put children at increased risk of chronic conditions in later life. This is costly for individuals and society. In upper middle income nations, pre-primary education is widespread, so B gets a head start in learning and social interaction. In low-income nations, many children will receive basic primary education. Girls, marginalized populations, and displaced people often fall behind. primary education levels have a huge impact on social, political, cultural, and economic conditions in a country. As a teenager, B has lessons in building better gender relationships and on reproductive health. The skills she learns will help her build lifelong relationships and avoid loneliness along the life cycle. In A's culture, girls marry young. With no access to education on sex and contraception, she cannot easily plan her family. When she becomes pregnant, she leaves school and is at greater risk of poverty, isolation, and domestic violence. Early pregnancy affects girls' health, education, and future financial potential. In upper-income nations, the average marriage age is older, so B has time and flexibility to make decisions on education and when to start a family or pursue a career. In all nations, especially in disadvantaged environments, sedentary lifestyles, increased consumption of sugars and fast food, as well as smoking, drug and alcohol use, escalates instances of conditions like hypertension, as well as cancer and diabetes. The life cycle approach must analyze changes in lifestyle and encourage lifelong exercise to reduce risk factors. While her husband goes overseas to work, A sells goods in a local market to support her family. This is low-paid and insecure work. B has access to childcare benefits and pension savings so she can plan for a future for their children. Reproductive health services help with family planning and fertility so she can plan pregnancies around her career. With no such access to family planning services, A soon has a second child. The birth leaves her with a fistula. Without universal health coverage or money to treat her problem, she suffers from incontinence, social stigma, and has fewer work opportunities as she heads into old age. B and her partner can save money from their jobs and have pensions. Lifelong universal health coverage and social benefits for the elderly reduces the burden of care for families. Now a widow at 60, A has moved in with her adult son. She worries about contributing to the household. Her small government pension does not cover the costs of medicine and food. Age-friendly policies and infrastructure allow B to enjoy an active lifestyle. At 70, she's able to work, volunteer, study and be independent, while having time to spend with her family. A suffers mobility issues. She spends long hours at home, caring for her grandchildren, a role she loves, but which she finds harder to fulfill as her health deteriorates. She is increasingly isolated and worried about the burden on her now grown children. The disparities in the lives of A and B are unfair but not inevitable. If more governments in the Asia-Pacific region emphasize a lifestyle approach to aging alongside economic development, millions of people could have improved life chances and a better likelihood of a happy older age. Early life intervention, universal health coverage, and an education that reduces harmful practices can be standard in all nations in the Asia-Pacific region. This life cycle approach requires changes in laws and attitudes to social protection, gender equality, universal health coverage, and how older people are treated. This is already happening. The Republic of Korea has passed an act of anti-discrimination and employment of older persons. In China, pensions reforms have incentivized workforce formalization and have increased coverage of social security systems. Japan promotes healthy aging with policies starting from pregnancy and childbirth through the whole life course. Its integrated system is based on long-term care insurance, the promotion of intergenerational solidarity, and the sustainability of an aging society. Policies such as these will help nations benefit from the ongoing demographic changes in Asia-Pacific, leading to wealthier, happier societies that benefit all generations.
2050年に日本は持続可能か。残念ながらいろんなデータとかですね、そういうのを見ますと、日本社会がこのままいくとかなり持続可能性の面で危ういといういろんな事実があると思うんですね。
In 2016, Kyoto University and Hitachi established the Hitachi Kyoto University Laboratory, based on a shared awareness of creating innovation and resolving social issues. The two partners announced a policy proposal towards achieving a sustainable Japan in 2050 by utilizing Hitachi AI technology.
日本の持続可能性、未来の持続可能性にとってですね、都市集中型か地方分散型か、そのいずれかが一番大きな分岐点になると そういう、AI のシミュレーション結果が出たんです。今から8年から10年後ぐらいに、都市集中型か地方分散型かのその大きな分岐が起こると。その分岐が一旦起こると、その2つの道はもうその後はもう交わることはないというのは、そういう、結構強い結果が出た。都市集中型と地方分散型を比べるとですね、人口の持続可能性とかですね、あるいは格差とか、そういった面から見ると都市集中型よりも地方分散型の方が望ましいというですね、そういうシミュレーション結果も出まして、我々がなんとなく思って感じていることを裏付けたというの、そういう面もあるかと思ってます。
So I think I'm going to sort of the finishing my slide or my talk by actually sharing my ideas based on the assumptions maybe actually sort of that I actually talk about so far. There are three actually sort of the layers of the proposals. One is actually the scoping review of the existing information and situation or the people by age in the context of COVID-19. Of course, in the main focus on older persons, on health and well-being, income security, and relationship. So far, yes, so many countries has been done a different type of studies. I think what we need to do is actually we need to accumulate that knowledge and actually it's been shared each other. So this conference is a really good opportunity for that. But we might actually want to do that in the actual written format, or actually even conduct a study on that. It's by systematic review. The second is the information commons in ASEAN. Well, during the sort of COVID-19 outbreak, I think what we and everybody actually had a difficulty accessing this information, even the sort of the simple statistics of mortality in older persons by the COVID-19. So the statistical data, as we've been advocating, it should be age aggregated. That age aggregated statistical data should be actually could be shared in a sort of the commons platform. But not only actually such a data or information, I think that like a policy catalog, yes, we actually published a policy catalog on population aging a while ago, a couple of months ago, but such a actually the catalog of the policy options for the population aging by the older person long-term care should be actually archived somewhere, then people have access to it. And it should be updated all the time. Well, UNFPA is happy to do that a little bit, on the voluntary basis, but we can actually unite together to do that, I guess. The third is, as I mentioned about the artificial intelligence, the work, the collaborative modeling of future scenarios in population aging. We have now some information around how the COVID-19 has an impact on the fertility behavior, how the COVID-19 is going to impact on migration, how the COVID-19 is going to impact on the older persons as well as aging. Now we can actually run the mathematical modeling to predict in the future or future scenarios. Depends on the policy the responses. So we actually focus on such a mega trends and a modeling to inform the major policy reform based on the COVID-19. Of course, I think the details or the near future predictions or the policy response to the current needs is very important. But at the same time, it is time for us to think about best for the long-term future. Thank you very much.
Thank you, Dr. Rintaro Mori, for the very informative and remarkable talk. The next session is country paper presentations, COVID-19 and Aging Studies. Please be informed that participants are welcome to post your question for each speaker in the chat box. It is now my pleasure to welcome the first presenter, Professor Dr. Ong Fon Sim, the Vice Provost, Teaching and Learning from University of Nottingham, Malaysia.
All right. Good morning, everyone. And First and foremost, I would like to thank the organizer for inviting me to speak at this conference. I'm very happy to be sharing with you the research that we have conducted on the changes in consumer behavior during the COVID-19 pandemic. And we're going to do a comparison of young and old adults. Listen to Dr. Mori earlier on for his keynote. And I must say that I'm so pleased to hear that he is using the life course perspective to look at aging. In fact, in my stream of research, we use a lot of the life course paradigm. In fact, what I'm going to present to you is only the first wave of our research. There will be a next wave where we are going to track the kind of changes that have taken place with regards to the pandemic. Next slide, please. Yep. So this is just to show you that University of Nottingham is one university, 3 campuses. So we have our main campus in the UK, Nottingham, and then we have our China campus in Ningbo and the Malaysia campus in Semenyih. Next, please. Okay, so just a bit of introduction, I would like to say that, COVID-19 is really a life-changing event that has affected people globally, but differently. So most would have experienced a lockdown, our crazy rush to stock up food. You can see supermarket empty shelves, and for some, even the loss of loved ones. So this is really a life-changing event in that sense, because it means that the person who have lost the loved ones would need to do, would have a change in their role and so on and so forth. I won't go into that because that's another area of research. Let me concentrate on the topic today. So for the first time, what we are talking about is that many consumers are faced with a situation where people will have to reassess their priorities in life. And sometimes they are forced to do things that they think violate their freedom. For example, we read in the press that, a lot of the Westerners don't like to wear a mask. They protest, they walk along the streets. But these are the things that required during the time of the pandemic. Next. So people may have also been socialized to new realities imposed by the pandemic and conform to new expected or imposed social norms. Example, work at home, social distancing, which are communicated to them by socialization agents, and etc. Now, people respond to such changing events by changing their attitude, their behavior, that include consumption habits, view also as events. So conformity to new norms and enactment of new roles due to COVID-19 also entails changes in the existing patterns of service consumption and the onset of new ones. For example, we are now having a teleconferencing, conference, and so on. Next. So many changes require adjustment and adaptation to new life. So we view the change mechanism that through stress and coping. So socialization and as well as human capital development or change. So any change is stressful. So I'm sure all of us experience the stress due to COVID-19, but we also learn how to cope and how to manage ourselves, make the best of what we could. Now, people also learn more about the transition of viruses. For example, when we have knowledge, we say that there is an increase in human capital and engage in activities that change the behavior in the marketplace, including the use of services. For example, home delivery, Grab Food, Panda, and so on and so forth in Malaysia. Next, please. So now I'm going to share with you what I have here. So this is a survey of Malaysians. We use panel data because, like I explained earlier, this is the first wave and you're going to have the second wave to track and to see whether some of the changes are really more permanent compared to those that are just required at one point in time. So we are going to look at the sources of information for COVID-19, knowledge about COVID, things that people do to avoid getting COVID, social distancing behavior, stress, life satisfaction, and of course, I'm going to show you the social demographic variables. Next, please. So this is the the result. We have a total of 778 respondents. So what is unfortunate is that we failed to recruit enough older people. So you can see that, the sample is very much skewed to those 45 years and below. So in my young and old comparison, I will have to use 46 and older to indicate older group, because in consumer behavior study, people in the late 40s are also considered as old in that sense, right? So of course we can argue, 60 is the new middle age, but for the purpose of this research, we will just use 46 and older as indicative of older people. So we have about half and half of male and female, and the education, because I think most of the people are younger, so you tend to see a skew towards respondents having university degree and so on. So I don't think I want to waste time on the rest of the demographic variables. So let's just move on to what interests us most for this conference, for this paper. Next. So you can see that, when we talk about the sources of information, it is interesting to note that, people rely a lot on the government announcement, for the updates and so on and so forth about COVID-19. People also tend to listen to TV and radio programs. I was a little bit surprised that I thought the social media would be much more ahead as a source of information, since this profile of the respondents are pretty young. But I think TV programs, TV, radio, and social media, I can say that they are almost at the same level of importance or of help to people. Then you have the newspapers and magazines, and of course, formal meetings or informal gatherings scored very low because this data is collected during the relaxed MCO period, where we are still in the MCO. Next, please. Next, please. So when we look at comparing the young and the old in terms of the information used, we can see that, there's not much of a significant differences between the young and the old, except for those highlighted in red. So you can see that the government announcement, surprisingly, the younger age group rely a lot on government and the old people less so. In the same vein, TV or radio program, again, the young people relied more on the source, and for the rest, where differences are found, again, the younger people seems to rely more on all these sources of information. Next, please. So then, I did factor analysis, just to show, to see whether our scale is pretty good, robust. So when I analyzed it using exploratory factor analysis, factor 1 all concentrated on the mass media, whereas factor 2 the items loaded on factor 2 are all those related to personal or interpersonal contact. So the Cronbach's alpha is 0.864, which is pretty good. The variance explained is close to 90%. Next, please. So then, we look at the knowledge about COVID. So we want to know exactly, how much people do know about COVID-19. If we have 778 respondents, I can say that, there is no perfect score or for any of the items. The highest one is that, fever, fatigue, dry cough, and then shortness of breath are common symptoms of COVID. So you can say that, 715, or as high as 92% of the people know that if you have all these symptoms, then, that is related to COVID. Then again, if you look at those that has got the lowest score, perhaps, is eating or contacting with animals would result in the infection by the COVID virus, all right? And the mean for the correct answers is about 7 items with a standard deviation of 1.64. Next, please. So if I compare the young and old, so when I divide the two groups into young and old, as I have explained to you earlier on, we can see that, the t-test is very significant. The mean for the younger age group and the higher age groups, as you would expect, the younger to know more. But in this case, I think the older age group has got more knowledge on COVID than the younger group. Now, this is perhaps with regards to attitude again, maybe older people, they are concerned, they are maybe a bit more concerned, maybe because they are deemed to be in the higher risk group because they may have illnesses that can cause detrimental effect if they are if they have COVID. So therefore, you can see that, we do not know what's the reason behind all this, but it is pretty clear that, the older age group has got a better knowledge on COVID. Next, please. Then we look at the behavior and day-to-day activities during COVID-19. Now, what has happened is that we have these items, about I became concerned about COVID-19, started using protective equipment and hygiene products, stock up certain items before big crowds, quarantine myself, working from home, change in financial status, like, for example, losing your job, reduction in salary, because that happens, we hear a lot of that. So we want to find out how far this is true. Keep physical distance from others and diagnosis of a chronic condition. So in our questionnaire, we captured all these. Before 2020, does it happen during January 2020, Feb? And in fact, March, we have got it very clearly demarcated because from 18th of March, we went on the control management order, or commonly known as a lockdown. And after 18 March, with a lockdown, April, May, all not experienced at all. So these are the statistics. As you can see, a lot of the times, the people become concerned about MCO, and the COVID is after the MCO. So when the lockdown started, people began to realize that, look, this is serious, yeah? And also working from home. So this is really has got to do with the government directives that we now have to work from home. And so a lot of things happen actually after the 18th of March with the movement control order. So with the MCO, the movement control order. Next, please. So then when I want to compare the young and the old, it is very, very difficult to capture across all the different periods. So what I have done is that So long as they indicated there is a change, they have experienced it, I will score it as 1. Those that do not experience is a 0. And then when I reorganize the data and captured it and comparing it between the young and the old, you can see that, there is not much of a significant differences across, except on becoming concerned on COVID-19, quarantine myself for 14 days, and then keep physical distance from others, and diagnosis of a chronic condition. So when it comes to diagnosis of a chronic condition, you would expect the older age group to be experiencing that, and that is true. And that also, it's keeping distance from others. The older people tend to be very concerned about observing the directives, that you should keep the social distance, right? And becoming concerned about COVID, also the older age group. So you can see that, if we start to compare the young and the old, you can see certain patterns that we can pretty much, explain, by what we can speculate the reasons behind those behavior. Next. So we also asked about social distancing behavior. The scale item is never, sometimes, most of the time, and always. So you can see the mean. We computed the mean, and as you can see, those two try to stay away from groups or crowds scored the highest, and so is these try to keep a distance of at least 1 meter. So if these two emerge as the highest score, then you can see that the government's continuous messaging about these two requirements, I think, has produced impact. Thank you. Next. Next, please. Thanks. Yep. So then we sorry, no, the previous one, sorry. The comparison. Yeah. So when we compare the social distancing, comparing the young and the old, the only one that emerged significant is try to stay at home. So it's surprisingly that, the young says that they try to stay at home more than the old. And perhaps the older people said, I didn't try to stay at home because I'm already staying at home. That could be a reason. So, that's why the score is a little bit low. Or the younger people tend to go out a lot, so therefore they have to think about staying at home more. Next. Next, please. Right. So now we come to the interesting part, where we actually look at the changes in consumer behavior. So we collected all those variables, and we now compute it, and we group it as we call changes in consumer behavior, change in hygienic protection and insurance behavior, and changes in general consumption behavior. So these 3 big blocks of changes in consumer behavior. So those that are under changes in consumer behavior, it will be items would include wearing a mask, using alcohol, shopping groceries online, buy larger quantity of products, use food delivery service, use social media, buy insurance, take online course, take on new hobby, save money, and things like that. Yep, and these are the items. The change in hygienic protection: wear a mask, use alcohol, wash hands, clean and disinfect home. And then if we have insurance, we will add the buy insurance. That will be the changes in the hygienic protection and insurance behavior. And changes in general consumption, there will be shopping groceries online, buy larger quantity of products, use food delivery services, take online courses, take on new hobby, and save money. So as we can see, we have the mean there and the mean changes. So we will add, if there is a change, we will score a 1, and then at the end of it, we will compute and we'll sum up the number of changes that people made. And at the same time, we also measure life satisfaction, acute stress, and chronic stress. Now, acute stress is related to COVID itself because, with COVID, how stressful. So, to be sure, there is no significant differences with regards to changes in in consumer behavior, in hygiene and insurance, or even in hygienic behavior or general consumption. Now, what has happened is that we found a significant difference with regards to chronic stress between the young and the old. And I think the old people tend to be more stressed up. Maybe they have got conditions to deal with, maybe illness, maybe worry about children, and maybe a lot of other worries and life-changing events. So therefore, their chronic stress level is higher compared to the younger age group. So next, please. Next, please. Yep. Okay, so when I try to find a correlation, looking at the correlation is just a simple correlation between the various dimensions of changes in consumption behavior with life satisfaction, chronic stress. We can see that, acute stress and changes in consumer behavior is positive. So that means the higher your acute stress, due to COVID-19, the more changes you're going to make with regards to your behavior in consumer behavior, in hygienic behavior, in your general consumption pattern. And that has got a significant relationship negatively with life satisfaction. That means the higher your acute stress level, the lower your life satisfaction would be. And this is to be expected. And also, acute stress has a very strong correlation with chronic stress, which means that, this acute stress as a result of COVID-19 contributed towards the level of chronic stress among our respondents. And this is very interesting to see, this pattern. So again, we find that, generally life satisfaction and chronic stress has a negative correlation. So these are all in the expected directions that we see. So I think my time for presentation is running up soon. So now I will just come to the discussion and conclusion. Next slide, please. So when we look at the socialization agents for changes in behavior, we can see that the government announcement is very helpful for people to learn about COVID-19 situation, and people relied on the mass media and less on personal sources. Knowledge about COVID is surprising because no one statement has a 100% correct answer. This could be due to the fact that some of the respondents have low level of education, as indicated under the demographic profile. As expected, many of the changes on day-to-day activities happened when the movement control order took place on 18 March. Then what is worth noting is that 74% of the respondents did not report any chronic condition, indicating that the resiliency of Malaysians. I would like to say that actually. Next, please. Okay. Then when you look at the stocking up of items, that took place in March before the MCO and the MCO period, and this is consistent with what we learned, from the mass media about empty shelves in supermarket, the rush for even toilet paper rolls, and people cannot understand why you need so much of toilet paper rolls, but never mind, but this is a human behavior. So we thought it only happens in Malaysia, but no, it happened in the Western countries as well. So this is worth what I call a cross-country survey, study of the East and the West behavior. So as high as 40% of the respondents did not experience any changes in financial status. And this is good as well, which means that, people do not have any pay cuts, or maybe did not lose job as what we understand it to be. social distancing behavior. At least more than 60% of the respondents were doing the things, expected during COVID, such as staying away from crowds, keeping a distance of at least 1 meter, indicating the effectiveness of the government's messages on the importance of social distancing in preventing and avoiding COVID-19. Now, when we compare the younger and the older age groups, which is the focus of our study, we see that, the comparison did not yield significant differences except on knowledge on COVID, becoming concerned about COVID, the quarantine behavior, keeping physical distance, diagnosis of chronic condition, and try to stay at home and chronic stress. So now the results showed the positive relationship between acute stress, chronic stress, and changes in consumer behavior. Now, so this chronic and acute and chronic stress also showed a significant negative relationship with life satisfaction, as I have explained earlier. Now, with that, next slide. Next slide, please. Thank you very much. I'm happy to receive any question. If there is time, I'll pass this back to the organizer. Listening.
Yeah, there seems a few questions from the participants. So I just sum up the questions. Hi, Prof. Dr. Ong. Could you elaborate on how changes were measured? You mentioned a score of 1 and 0 and summing up these scores, but I didn't quite understand it. Hope you could provide more details. Question number 2. What is the measurement of acute stress and chronic stress? Is this a phone survey? Thank you very much.
Okay, so first question is on how do I do the sum up the changes in consumption behavior. So if you still recall, we have got the, if you can go back to the, so you see, if you go back to the slide on behavior and day-to-day activities during COVID-19, sorry, let's go back to the one on the changes in consumption behavior. So these are the items, wearing a mask, use alcohol gel, shop groceries online, buy larger quantities of products, use food delivery service, use social media, buy insurance, take online courses, take on new hobby, save money. So we have how many items? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We have 10 items. So if a respondent put a 1 under each of these items, which means that we would expect that the respondent has made 10 changes. Okay? Whereas another respondent may indicate only 1 or 2 changes. So we will we will use the compute command in the SPSS and we will compute. We add wear a mask, add use alcohol gel, add shop groceries online, and so on and so forth. Then for each respondents, we can see the number of changes that each of them made with regards to these 10 items. At the end of it, when we run mean, we will then be able to get the score. So is this clear? I'm not sure whether that is clear. Can the organizer please help to get the our participants to indicate whether this is clear enough? If not, I can explain further. So we do similarly all these things for the other consumption behavior. So the chronic stress that we use to measure chronic stress is from the scale. We use the scale of, there's Dinner et al. So in most ways, oh no, sorry, this is life satisfaction, chronic stress. I tend to react a lot to situations. I'm touchy. I find it hard to wind down. These are the items. What I can suggest is that if any of the participants are interested in the scale and how we do this research, please provide my email address to them, and I can individually answer them, and also by providing them with a scale. I think that would be more effective than running it through the items where you might not be able to capture properly. Is that a better suggestion, please?
Yeah, certainly. Okay, Prof. Okay, thank you very much, Prof. Dr. Ong, for the presentations and question and answers session. So, moving on to the next presenter, please welcome Associate Professor Dr. Rahimah Ibrahim, the Deputy Director of Malaysian Research Institute on Aging, MyAging, University Putra, Malaysia. Okay, we would like to welcome Associate Professor Dr. Rahimah Ibrahim, the Deputy Director of Malaysian Research Institute on Aging, MyAging, University Putra, Malaysia.
Thank you, Chairperson. Dr. Hayati, Assalamualaikum and a very good morning to our distinguished guests from various ministries, departments, agencies, academic or research institutions, and voluntary organizations. Ladies and gentlemen, allow me to provide an overview of a research project entitled Supporting the Aged Care Sector During the COVID-19 Pandemic. The topic today will focus on the online training of infection prevention control in the aged care sector. The response to COVID-19 pandemic has been from a crisis management to navigating the new normal. Next slide, please. Outbreak of a new virus, the novel Severe Acute Respiratory Syndrome Coronavirus 2 or SARS-CoV-2, and it has brought profound impact on our public health and the economy and caused a lot of societal upheaval. In this time of COVID-19 outbreak, the focus on older people is twofold. Older adults, they are the group that is most vulnerable to COVID-19, and those who are infected have a higher risk of death. This is due to the fact of advancing age, underlying chronic diseases, and gender. These are known predictors of infected persons' risk of dying. Secondly, people who live in residential care facilities, these group are at a higher risk of being infected with COVID-19, and it is estimated that the fatality for older age groups also depend on the healthcare system's capacity and whether the virus has spread among the care staff and also the residents. So the world as we know now is no longer the same due to the outbreak of the coronavirus disease. As of yesterday, the COVID-19 dashboard in Johns Hopkins University showed that there are 73 million people worldwide who have been infected and 1.6 million who have perished in this pandemic. In Malaysia, there are nearly 85,000 confirmed cases and a total of 419 people have died from the virus. Next slide, please. Okay, the exact number of people who are affected in the long term or in the residential care sector is not made publicly available, and as such we do not know very much about the details of each outbreak. But what is known to us is that there are 4 older persons clusters, one in Selangor, 3 in Selangor and 1 in Kluang Johor, with infected, the stated number of people infected and also death. These are due to the outbreaks in the care facilities, and some of the infections are caused from the discharge of a resident from a hospital, or that a staff who has traveled overseas and did not go through proper quarantine. Okay, there's a paper on this. You can look for the paper and download it from the web. The title is The Long-Term Care COVID-19 Situation in Malaysia by the various authors. Next, please. Okay. The World Health Organization has provided a policy brief which highlighted the key action points to prevent and manage COVID-19 across the long-term care. This is due to the fact that COVID-19 pandemic has affected older persons disproportionately, especially those living in long-term care facilities. The evidence shows that there are more than 40% of COVID-19 related deaths have been linked to long-term care facilities, and some as high as 80% in high-income countries. So this is to build on the currently available evidence on the measures taken to prevent, prepare, and to respond to the COVID-19 pandemic. Okay, next slide, please. Let me give a bit of a background about the project. Whole sector measures have been driven through coordinated efforts with the Association of Aged Care Operators of Malaysia. We also work with medical societies, Ministry of Health departments, Selangor COVID-19 Task Force, the Ministry of Welfare, and researchers from the Malaysian Aging Research Institute, and they have developed a guideline of interim recommendations for the COVID-19 pandemic in private, public, and NGO residential aged care facilities. And the adoption of these interim recommendations was announced by the Director General of Health on April 16. And on May 2nd, the Director General of Health announced that all care home staff and residents will be tested, and it will include all the unregistered homes as well as pondoks. The project title is supporting the aged care sector in preventing and mitigating negative impact of COVID-19 on older persons in Malaysia. This is funded by the WHO Regional Office on a short-term funding, which started in June 2020 with an amount of Ringgit Malaysia 200,000. Next, please. The objectives of the project is mainly to improve the early recognition, prevention, response, and control of COVID-19 among older persons living in institutions and the community at large. The specific objectives are as follows. First, to follow related government agencies to support related government agencies in the comprehensive development of guidelines for the welfare and care management of older persons in the long-term care during COVID-19 pandemic period. Second, to evaluate the needs of at-risk and vulnerable older persons and assess the operational challenges of relevant health and social aged care providers in managing the risks and impact of COVID-19 on the elderly. And third, to strengthen the capacity of aged care service providers, including care workers and the family caregivers, in the management of older persons with chronic multimorbidity during COVID-19 pandemic period by coordinating information and resources across different sectors and at all levels. Next, please. There are three main project deliverables. First is the infection control training module, in which we target to train 200 homes. Second is the behavioral and aged care industry surveys. This is conducted via online or followed up by telephone. The third is the online directory of aged care providers. This is done in collaboration with the association AgeCope, and the homes will be able to upload and update their details. Next. These are the project activities that we have done so far supporting for this project. The first is the infection control training module development. This is a multi-institution, multidiscipline module developers who have contributed to the module development. Second is the behavioral insight survey and aged care industry survey, and also the development of a national directory of residential aged care in Malaysia. And the third one is the implementation of infection control training program, which I will highlight in this presentation. Next. Okay, the implementation of the infection prevention and control training program follow a 7-course implementation plan, which begins with a program launch and briefing. Next slide, please. A program briefing is included to orientate participants to the course. An overview of the research and information about the training program was provided, and participants were taken to walk through the Putra MOOC system, the Putra Massive Open Online Courses System, which is a global initiative to benefit the local and international community in online learning. Next. The next step is the Putra MOOC registration support. Participants were given a course start date, and in the meantime, the research support team will register participants into the Putra MOOC system, and they are assigned to a group of 20 people, approximately 20 people. And with the registration ID and password, the participants can log on to the Putra MOOC system and start their learning. Next slide, please. The participants were given 7 days to learn the materials. This is a self-paced learning of the 10 modules. Module topics are condensed into short narrated PowerPoints, and the total estimated learning time for the course is 24 hours. The course contains activities and assessment, and participants may spend on their own time to do some activities and also group work that is required of the course. And the first module on introduction of COVID-19 is a prerequisite before they go on to the next topics. Next, please. The activities and assessment during the learning period include completing the short quizzes and assigned activities. This is 60% of the course total. There's also a infection prevention and control demonstration, which requires participants to submit photos or videos of measures that they have practiced in their facilities, or personal experiences, or any takeaway lessons from the training. This is 30% of the course. And finally, participants have to provide a feedback on a survey about the course. This is also 10%. Participants can earn 6 CPD points from the course. Next, please. An online synchronous session was provided with the facilitators. This is to allow participants to ask questions and to give their feedback. And participants were assigned into breakout sessions in groups with their facilitators, and their feedback were used to improve the program. Next. The sixth step is we also included panel evaluation of the photos and videos that they have submitted, and we created a competition. An entrance into competition will be shortlisted, and the photos and videos submitted by participants will be evaluated by a panel of judges, and prizes will be awarded to homes with most comprehensive and creative IPC measures. Next slide, please. And finally, participants can get a certificate of completion, and they are eligible to claim 6 CPD points. And the homes with who are the winners of the categories will also receive a certificate of award. Next slide, please. Okay, what are the lessons learned from from implementing this training program? This is based on the preliminary learning statistics and also follow-up sessions with participants. First, we learned that digital learning is a big leap for aged care workers. There were very high interest when we introduced or promote the course to them. We had around 200 interests participants who registered their interest to go into the course, but there is a very low completion with very high attrition rate throughout the program. The participants stated their preferences for synchronous learning and also interactive sessions, but these are currently limited. There are some limitations during the lockdown because participants have to, some of them have to be quarantined together with the residents in the aged care sector. And it can also conflict with their work schedule. Other barriers to learning are situational. Participants complained of lack of time, and other barriers include dispositional factors such as low motivation and lack of discipline to follow through the course. Third one is institutional barriers. It conflicts with their schedule, and also technical barriers due to the lack of access to computer or internet. There are also some requirements by the MOOC platform that they couldn't understand. And basically, there's a very large digital gap among the participants. Next, please. So, adult learning is very much disrupted during this pandemic due to gaps in digital literacy, including access, utilization, and capacity. And all these factors affects informal, non-formal, and formal learning. Next, please. The OECD have also published a study in July stating the factors or the barriers to participation in adult learning, and the highest factor was noted in terms of the work-related shortage of time. So this is very much an issue when we also found similar issues when we ran the course. Next. So in terms of challenges and way forward, this is also based on a study that was published by the EU on adult learning and COVID-19 challenges and opportunities. So there are main challenges for adult learning in dealing with COVID-19. There are sector level challenges and also the challenges at the level of adult learners and educators. And these challenges needs to be addressed in order to ensure that the training can be done in the increasingly digitalized platform of learning post-COVID-19. So it is important for country to provide, these are some of the responses that the EU countries have taken to respond to the challenges. For example, providing financial support to the sector and adult learners, providing information and instructions how to deal with the COVID-19 situation and making the adult learning offer transparent, combining different media to overcome infrastructural challenges to adult learners. This is something that we can do. We have to combine traditional and digital learning techniques, and also to provide support to educators and providers through making available assistance, learning materials, and online training. And in the next course offering, we are going to create a learning partner so that the learning process is scaffolded and has more collaborative activities. And we want to include more, we will recruit the coaches of facility trainers from the aged care facilities, and also promote this digital learning, because this is the way forward, and this digitally enhanced learning can bring many potentials if all the challenges are addressed. So with that, thank you. That's all from me. If you have any questions, I'll be more than happy to answer it later.
Associate Professor Dr. Rahimah, it seems that there is no question at the moment. So we move on to the next presenter, Associate Professor Dr. Hadiza H. Abdul Mumin from University Brunei Darussalam. Please welcome, Professor.
Right, so I'm going to present a research that we conduct as a team on the experience of caregivers of the elderly during the COVID-19 pandemic. So basically the research is conducted during the and it went through until when COVID is actually subsiding from Brunei. So as you all know, at the moment, COVID-19 cases in Brunei is about 150 plus, and only one active cases at the moment, which is treated. Okay, can we go on immediately to the slide? Okay, so next slide, please. Right. So in the Holy Quran, it is said that kun fayakun, whereby when Allah said something to happen, it will happen. So then we go to the next slide. Next slide, please. Where we are affected by COVID. Everyone knows that COVID is caused by SARS-CoV-2 pathogen, and it has been a threat locally and internationally. And as we all know, we have a lot of measures. Okay, I like the way they did it in Malaysia. 3S. So you know, no social contact, which is maintain social and physical distancing. No contact, don't touch, and all those kind of things. We have a lot of interventions actually that happens, but these interventions and procedures have a lot of implications to the caregivers whom are involved with caring of the elderly. We move on to the next slide, please. So in order for us to be able to function normally, we don't want to cause harm, and also we don't want to get harm. So then we come over to the next slide, which is an introduction of our research team. Next slide, please. So this is the elderly. We have a project which we call ECQC 24 project, which is the elderly caregiver questionnaire for COVID-19, which is the ECQC 24. That's the picture of my daughter with her grandma. Okay, so can we move on to the next slide, please? So these are all our research team, which is led by Dr. Lin Naing, which is our professor in biostatistics, Dr. Hanif Abdul Rahman, which is our biostatistics as well, but he is very good with instrument development and validation. Dr. Dini Rudita, which is a mental health and a men's health specialist. Dr. Hajjah Fazian, our medical officer, who is very good with general practice, and myself in nursing and midwifery. We move on to the next slide, please. Right, so here are the mission of our project. So we know that COVID-19 is a very dangerous disease. It affects, in the United States itself, 79.4% recorded death is those aged 65 and above. So we know that during the COVID-19 pandemic, we need to isolate the elderly population. We need to give public education so that we can protect the elderly people. So we created the questionnaire. Next slide, please. And in the questionnaire, we actually have 24 questions, and that's why it's called ECQC 24. So elderly COVID questionnaire for COVID-19, elderly caregiver questionnaire for COVID-19. And this is derived from extensive literature search, which include guidelines from World Health Organization, CDC of the US, and also IAGG. We measure 3 components, and of that, it includes knowledge, attitude, and practice. As you can see there, I don't have to say it one by one. Next one. Next slide, please. But today, my role is as a qualitative researcher. I will share with you the findings from the qualitative section of that questionnaire, which is concerning 2 things. The first one is if the carers have concern with caring for elderly persons during the COVID-19 pandemic. And also the second one is the knowledge and skills that they would like to have. What are the skills that they would like to have? Next slide, please. So then it comes to the methods. Okay, so in the methods, we actually target the elderly caregivers. We set 2 open-ended questions, which you see just now, and we disseminate the questionnaire through Qualtrics. We have targeted informal caregiver, whom is the primary caregiver for the elderly person, and they must be 18 years of age and more, on the sense that it's easier for us to get consent. And of course, they must be able to read and use the phone or computer, because the questionnaire is disseminated through Qualtrics. And we also target 1 caregiver at least per elderly answer the questionnaire, and we disseminate the link to caregivers through the elderly who attend the daycare center in all the districts in Brunei. Next slide, please. So what happened is, at the moment, we have about 100 responses for the quantitative bit. So I have a look at Qualtrics and pull out some of the answers that they have for the qualitative section. And we have developed 3 themes from it. The first theme is, of course, fear, anxiety, and uncertainty, which is I got from the words are yet to come. So some of the fear or anxiety or uncertainty that they have is they question themselves what happened if their mom or their dad suddenly confirmed to have COVID. So when they write, they didn't put COVID-19, they just put COVID. So and then they also have the fear of being a passenger of COVID. So uh, one of the respondent of the questionnaire write that when he or she came home, he or she goes straight to the bath and sometimes felt that they are overdoing or overboard, having bath again and again, and don't want to transmit the disease to the parents. So should they be concerned? And their worry is, and all people is positive for COVID, and then they're tested negative before discharge, and then is it safe? So they are uncertain. Is it safe for them to be with the agent who have been positive but then negative and being discharged? So during the heightened COVID outbreak, there is a fear that every day the worst are yet to come, and there is a concern on how best to protect the mother from getting COVID. Next slide, please. All right. So in this slide, I'm sorry. Go back to the previous slide. Sorry. Can you go back to the previous slide? Okay. So this is a few more example. So one of the answer that they gave is there is both parents are high risk, and the dad have hypertension and the mother have cancer. So what is the appropriate way to protect from COVID? And then another quote that I got is, which is written, if there are no cure for COVID, why these people are admitted? What good it is? So they know that it is for selecting and maintaining no contact, but since there is no cure, they wanted to know how does COVID disappear from that person. So and then another one is, as much as possible, I wanted to protect my mother. So they are very worried about the elderly that they cared for. And if possible, one person says that he or she wanted the grandpa to stay at home all the time, don't go at the mall or wandering and having coffee. Even now in Brunei, we have restaurants are open now. So this person says that he would rather the grandpa stay at home if he does not have anything important to deal with. So, but on top of that, there is also another sentiment, which is, when is this pandemic going to end? So that's uncertainty. Like, worry about the father, do not want him to get COVID, and very concerned about exposing, because they are worried that they're contracting COVID and that they might infect the elderly people that they care for. So we go to the next slide. In this slide, the second theme, which is not confident or they have limited knowledge. So there is a quote that has been written there. It says, knowledge is power, but if we use it. So basically, this participant or respondent of the questionnaire, they are not sure what to do to fully prevent their parents from getting COVID. And again, when I look into the questionnaire answer, they have the knowledge about COVID, but they're not confident. So how do they know that the knowledge is accurate? It says here, knowledge is power, but if we use it. So this person say, I'm concerned and I'm afraid of giving the wrong information. So afraid of giving the wrong information to the elderly people that they cared for. Again, the same fear or a feeling of not confident. They don't know how to actually explain to their parents, because during the heightened COVID-19 pandemic, we are restricted from our movement. Like, we are not allowed to just gather anywhere that we want, because in Brunei we have a tradition by which the old people, they will go out of their house and having coffee in the restaurant, meeting their friend, because that's the only way that they can socialize with their friends. So, but during COVID, they have to stay at home, and their children can't visit them as often. So, there is a situation by which some elderly may not understand this, and this is evident in the answer given. And another quote that I take is, I wanted to learn what knowledge should I have for taking care of my auntie. So whether it is the fact that COVID-19 heightened, or whether it is um, because of the chaos management, we said that we are prepared. We are prepared for COVID-19 pandemic to come over to anywhere in the world. But what we don't realize is that, are we prepared enough? So that may be the causes of not confidence. Can we move on to the next slide? Few things again. So it says there, I need knowledge about how to know COVID infect the mother, so sign and symptoms. Some felt that they don't have enough knowledge. Um, as simple as how to explain of what are the things that can be done and what cannot be done. And then sometimes they feel not confident to advise about the needs to stay at home, just simply because these high risk people. Why if they are high risk, they can go out and they can't be as free as younger people. Even if younger people also, they can't go out also, just unnecessarily during the heightened COVID-19 pandemic. So some write that they wanted to learn about COVID vaccine, which is just released, I think, a week ago, and then about the vaccine side effect. So is it safe to be taken? Is it really effective? Let me move on to the next slide. In the next slide, we have theme 3. Move on to the next slide, please. Okay, in this next slide, it's about the psychological well-being. So in this psychological well-being, the main thing that they said is caring for my heart. So if you can see there, one of the quotes says, I am worried. My mom do not want to shake hands with me. Has COVID-19 ripped our relationship and torn us apart? I feel disturbed as this is not normal. So not in our family tradition, not in our culture, shall I be concerned about my feelings. Some others write that they are stressed, worry about their father, concerned about the mental condition affected by COVID, and they would like to learn the skills on reassuring their parents about COVID and skill in negotiating. Because sometimes, as I said earlier, in the Malay culture, especially, not only in the Malay culture, but all people, senior citizens in Brunei, they like to sit down at the restaurant and having coffee. So another skills that they want to know is what activities and options can be done during the self-isolation and also during the restriction movement order. So another interesting, I thought, is the media, because it says there, media making my family panic. I expect media help with our anxiousness. All right. So moving on to the next slide. So actually, I didn't expect a lot of from the 100 questionnaire that come back in the Qualtrics, about 40, close to 40, or 40, but not as much as 50, but close to 40 are being answered. The qualitative section are being answered. It looks like the questionnaire was used as a medium of winding out their mixed emotions and concerns, rather than talking about what are the specific skills that they wanted to learn. Moving on to the next slide. So in the next slide, you can see there what is written in the answer on the qualification, reflecting the process undertaken by the caregivers in caring for the elderly with COVID-19 and reflecting whether their mentality are strong and they want the skills in communicating, negotiating, and reassuring the media influence. Like, this is what they expect, but the reality is it's not. Probably from the government side or the higher authority, the main reason why we do the media is to be transparent. But probably for the carers of the elderly, not only them, probably for the rest of the people in Brunei or in any other part of the world, media having a transparency might have a negative influence to them. And moving on to the next slide. Right. So what they written in the answer on the question of the open-ended action is the needs for self-care management and the needs for prioritizing the care. And probably most important is the importance of being resilient and consistent with the spiritual and religious practice. So I think probably what's important now is because all the research team are academics, it's very important for us to use the findings to inform our educational curriculum because not only we instill the knowledge there, but also the students can talk about what they learn with their family whom are also caregivers of the elderly. Can we move on to the next slide? So what we have done was we do a thematic analysis on the qualitative data, but the data is still raw. It's about 40 and close to 50 who wrote the answer for the qualitative section. But the thing is, some are short answer, some give as short as one line, some give as long as what you've seen just now. But it is still preliminary and we're still doing the ongoing thematic analysis. And quantitative data is also being prepared by Dr. Hanif for analysis. So if you want to use the ECQC, you can always contact us. We can share the tools for you. So indeed, Allah will not change the condition of people until they change what is in themselves. So that comes again to the next slide, where that's the reason why we are doing this research, right? Because we want to change the situation. We want to find out what happened out there, what happened to the carers of the elderly out there, what do they need. But in fact, during the heightened pandemic of COVID-19, all they want is to wind out their feelings, their emotions. So the questionnaire that we gave for collecting the data was used as some platform to wind up their concern. Can we go on to the next slide? So I think with that, I would like to say thank you. So we can have a discussion, or you can always email us. I have given the email address. I'm sure the slides will be shared with the rest of the participants. So please do not hesitate to contact us on that. So I think thank you very much, and that's it from me. Thank you so much to the organizer for accepting this paper as a country paper, and thank you to the audience for attending the conference. Thank you so much.
Thank you, Associate Professor Dr. Hadiza. Are there any questions from the participants? A question to Associate Professor Dr. Hadiza. What are the main challenges when you conducted this study?
Okay. One thing is to get the elderly to be on Zoom, to actually invite, for us to invite the carers, the caregivers. It took us more than a month to actually get response for our questionnaire, because we have to contact the manager of each of the daycare center. That's one thing. And then the second thing is to get to the director of the Ministry of Culture, Youth and Sport to actually communicate with the elderly so that they can disseminate the Qualtrics link to the questionnaire. I think that's the most challenging bit. And then we were not allowed to meet the elderly face to face, so we have to only talk with the manager of the daycare center over Zoom meeting and also over WhatsApp communication.
Thank you, Associate Professor Dr. Hadiza. Okay, please welcome our next presenter, Ms. Lee Kim Liang. She is the Deputy Director of the Elderly Welfare Department, Ministry of Social Affairs, Veterans and Youth Rehabilitation, Cambodia.
Yeah, thank you. Thank you, Madam Chair. Good morning, and Excellency lady and gentlemen. I'm from Cambodia, Deputy of Director Elderly Welfare Department. I have just share some of experience response to the COVID-19 vulnerable group and families. Yeah, can you show me, the slide, please? Next slide. Next, please. Next. You go. Yeah, to the content. Yes, my content is how the policies. Second is ID pool. Third is the program, and for each the challenge, and find the next step is for the COVID-19. Next slide, please. Next slide, please. Yes. Now Cambodia used the National Social Protection Policy Framework 2015 to 2025 for the vulnerable group in COVID situation now. Yeah. Yes. And about first here, this slide is showing about the statement facilitate the access to the social protection with appropriate allocation of the public fund for social spending, provides access to all essential goods and services to safeguard the well-being and livelihood of the poor children, older persons with disability, women and girls, migrant workers, and other vulnerable groups in time of crisis. Yeah, next slide. Yes, about this slide here, we show you about the benefit of the ID pool card. Like we have the free medical treatment at the public healthcare facility. Yeah, we use about this card here when we go to the hospital for the poor people. You can show about this card to the staff at the hospital, and so they will for you the free medical treatment. Yeah, go on, next slide. And benefit of the ID pool here, we got a transportation support by some NGOs for ID pool holder to the public healthcare facility, like about the transport, about the public health. So it's free for the poor family, for like we have got the ID pool 1, ID pool 2, so they can use the ID card, poor card family to show them. So they will no need to pay the money. Yeah, next. Next slide, please. So the program here, we got the cash transfer for poor families and vulnerable groups during COVID-19, and the second one is cash transfer for poor pregnant women and children under 2 years old. So about during this group here, we use the cash transfer for poor family and vulnerable group during the COVID-19, and before COVID-19, we also implementing about the cash transfer for poor pregnant women and children under 2 years old. The pregnant women to the healthcare center, you check for the baby every month, so you got free, or you have the ID card to put the card, like the health card to show the staff there, so free for checkup every month. Yeah, go on, please. Yeah, about this chart here, cash transfer for poor family and vulnerable group during COVID-19, like people who have ID pool card can come to check their name in any commune office which is near their home or their accommodation. Like the chart here, we got in first chart here, we got a budget support for monthly poor one. So poor one, I mean the poorest. We got like a family in downtown in Phnom Penh, and family in downtown outside Phnom Penh, and family in a rural area. Like family health and ID pool card got in family in downtown in Phnom Penh get $30, and family in downtown outside Phnom Penh get $30 too, and family in rural area only $20. Like each member of the families got $13, and family in downtown outside Phnom Penh is $10, and family in rural area $6. Like each children under 5 years old $10, and family in downtown outside Phnom Penh $10, and family in rural area $6. Like each PWD, people with disability, family in downtown in Phnom Penh $10, and family in downtown outside Phnom Penh $10, and family in rural area is $6. Like each elderly over 60 years old, family in downtown in Phnom Penh is $10, and family in downtown outside Phnom Penh is $10. Family in rural area is $6. And we also provide for the who got HIV positive member, like downtown in Phnom Penh, outside of Phnom Penh also $10, and family in rural area is $6. And about this side, the chart here is poor two, it's like medium poor, and the poor one is the poorest. Yeah, just a bit different. Like here 30, family health and equity card $30, and $20. And each member of the families $9, $7, and $4. And each children under 5 years old $7, and $4. Like I go to the each elderly over 60 years old $7, and $4. It means family in downtown and outside of the Phnom Penh is the same amount. But family in rural area only $4. And also we provide for the HIV, $7, and $4. Yeah, go on the next slide, please. Yes, about the result of implementing the program by November 24, 2020, it's around 3, and our Prime Minister Hun Sen will continue to the 3 more months. It means January, April, and March, and after that we will step by step how to deal with this. The implementing, like we have the line ministry for to implement about this policy, like we have the Ministry of Health, Ministry of Planning, and Ministry of Social Affairs, and Ministry of Finance, have to cooperate and to work together. About this, like this chart here, we got the poor 1 and poor 2. Family in downtown in Phnom Penh, and family in downtown outside Phnom Penh, and family in rural area. So it means you see the chart of the elderly over 60 of age, so it's the number of the people that get that we have to implement the money. Like the total amount here, it means US dollar here. Now we said about 24 November we use over 30 million US dollar for the whole for the member. It 600 so it means 674,000 like the member in here. Sorry about that number. It's for me it's not easy to count for you. So can you go to the next slide, please? Please move to the next slide. Yes, about the result to the death, the number of the families I show you. Please can you change the number of it, not 624, it's 674. Yeah, because we update this number is the round 2, and the round 3 now is 674. You can you change this number, and it means the total here is it means can you try or you change? I just show about this or not. 6,074 and 146 about the household, and the budget amount use the money here is the Khmer Rial, but the US dollar is over 30 million US dollar, and amount is 112 million USD. Please move to the next slide, please. Yeah, about our challenge of the program implementation. Like first, is timely resolution of the grievance and complaint. Second, no information about the program, procedure, source, or budget. Third, missing or damaged equity card and forgot the password. Fourth, no head of household in the card, like cannot pay, something like that, and like edit equity card number, dissatisfied with relocation of unverified card, expired card, and other type of card, like unhappy with getting different budget. Yeah, about this our challenge. Like in the rural area, they say that why I get less than you and why you get more than me. It means like in the local government works, they are with the authority have to it means how the criteria to choose who that poor one and who is poor to give the ID card for them, and they can to get the money. So it's hard for the for our work to the people at the rural area too. Like please to the next step. Next slide, please. Yeah, like why next step forward, I will continue to the disseminate program awareness to the beneficiaries, like participate in resolving irregularity or overall and benefit law, provide support to the provincial Department of Social Affairs, Veteran and Youth Rehabilitation in implementing program and planning department to identify poor family on request, strengthen sub-national administration mechanism to support effective program implementation. Yes, like yesterday I watched the news that our Prime Minister have to continue to implement about the cash transfer for more 3 months to the next year for the COVID-19. Please move to the next step. Next slide, please. Yeah, like we here continue about that. Continue to support and strengthen the capacity of commune, especially when changing people in charge. Continue to monitor the implementation of the program in the commune and meet with the beneficiaries, collaborate with capital and provincial administration, department planning to strengthen the implementation of the program to ensure compliance with the principle, resolve issues and complaints in a timely manner, like irregularity of commune and beneficiary, report to the capital, province and ministry to the health solve the problem that they can not solve. Yeah, like the authority, the provincial government, some case or some problem they cannot solve. I mean the capital have to, like our ministry and line ministry have to go to solve the problem with the people at the rural area. So my last slide. Thank you about that. And it's just my my government to implement the policy about national social protection policy framework. So I can share you some information that our country to help people in the difficult situation like in rural area outside of the country that they don't have job, and we can earn money. Some factory that close, and maybe not only Cambodia, many countries like Vietnam, Thailand, and I think our region also affects about this. Like Dr. the second and the first presenter also show about the effective of the COVID-19. So around the world affected by the COVID-19, just our government how to deal with it, how to use the policy to implement our work with this difficult situation together. Yeah, thank you for my presentation, and if I can give you some information or can answer your question, anything, yes. So thank you.
Okay, thank you, Ms. Lee. There is one question for you from the participant. The cash that has been given to the poor family and vulnerable group, is it given daily or monthly?
We give the monthly.
Please welcome the last presenter for the morning session, Dr. Duong Minh Duc from Hanoi University of Public Health, Vietnam.
Good morning, ladies and gentlemen, and thanks for the organization to give me the chance to present my research study on elderly and the quality of life of elderly in some of the provinces in Vietnam. So please help me with the first slide, please. Thank you. Yeah, so you can see that my presentation today is about assessment of a model healthy aging to improve the elderly healthcare in Vietnam. But that is a big project. I will focus more on how the quality of life changing a little bit in the healthy aging model that we have done so far in Vietnam. Next slide, please. So my presentation today is about 5 main points. The first one is talking about the introduction of the elderly and elderly healthcare in the country. The second is talking about the objective of the presentation today, and then a little bit about what we have done so far to achieve the objective by the method. And the next one is the result we have on the quality of life of elderly in some provinces in the country. And the next one is about some recommendation we have for how to make the elderly in Vietnam healthier. Please, could you come to the next slide? Yeah, so about a bit introduction about the country. So you know where Vietnam is. It's one of the country in the Southeast Asia, and we are one of the country with around 96 millions of residents. So you can see that we are we are the 15th populous country in the world, and we are also one of the country who got the fastest aging population in the world. For around 20 years, from 1990 to 2011, the aging population in the country had increased from 7.1% to 10%, and by 2019, from our demographic health surveillance, we got 11.8% of the elderly, which I mean here is the people who are aging 60 or higher. And then people with 65 years old and higher, we got 7.7%. So following the definition of the WHO, World Health Organization, the country have become a country with the aging population. So we have to deal with the aging population, which is one of the big problem in the country, because we are not prepared for the aging and elderly. You know, in Japan, a very high income country, they got around 50 years to prepare from a huge population coming to the age population. In US, they have around 100 years to prepare the transition from the youth population to the aging population. But in Vietnam, we have only 20 years from now to prepare for the aging population. So we will have a big problem to how to deal with them and how to make them healthier. Next slide, please. Yeah, so you can see here there are some major issues for the aging population in the country. The first one, when the country become from youth to aging population so fast like Vietnam, we have to deal with the burden with the medical care, which is too fast for us to prepare. We don't have enough resources, and also equipment and facility to deal with the medical care for the aging population. The second thing is that we don't have a proper roles elderly. What they will do, what they will contribute to the society, when become more and more now in Vietnam. Normally in Vietnam, we follow generation can live also, so the elderly can help the parent to take care of the children. But now with a very good kindergarten system, and we are more become to the nuclear family. One family is only have parents and the children, so the elderly they have to live alone, and they don't have much connection with the younger or with their children. It's a quite big transition now in Vietnam when we become a very big family with many generations, and we become only 2 generations, and it makes more difficult for us to take care of the elderly, because we don't have enough health system and also social system to take care of them in like nursing home, like hospital, special hospital, and so on. And the next one is a public awareness of the aging population, because we still think we are the huge country, so we think that the aging is not very Vietnam. It's only in US, in Japan, in high income country. But actually, with all of the statistical criteria, we become an aging population. So we now have this situation. And the next one, we already have the number on the number elderly. We don't have other information like how many of the elderly who are living with a non-communicable disease, how the elderly who are living with disability, and how many people with elderly health. So surveillance system or routine health information system to collecting data on health issues and other issues of the elderly. Next slide, please. So you can see here is a healthy aging analytic framework. This is from WHO in one of the publications 2015 about healthy aging in the world. And you can see here, take care of the elderly. We have to be to work with the 3 levels. The first one is a health service. The second one is long-term care, and the third one is how to make environment for health care. So you can see, in order to make the elderly healthier, we have to do the 3 things at the same time. To how to provide long-term care home, not at the or any clinic. So to make them a better long-term care at home, we have to do some community-based, and we have to do a lot of improve the awareness from the community, awareness from their relative system to be prepared to adapt their demand on health and also social issues. Next slide, please. Well, sometimes it happens when we cannot actively control the slide. Thank you very much. Yeah. So based on that, it's important to evaluate the health situation of the elderly. So that's why in 2019 we do one survey in the big city and trying to in Vietnam and trying to explore the current health situation of the elderly in the 2 provinces, and with the hope that from the situation we can inform the health policy maker about the current situation of the elderly, and to give advice on what is proper healthcare model for them to improve the health for the elderly in the country. So we have done trying to you can see the 2 objectives in the current slide, and then the first one is trying to explore the current situation. The second one is trying to analyze the impact factor relating their quality of life. So as I said, evidence is very important because we don't have the routine health information system to tell exactly how the health situation of the elderly in the country. Next slide, please. So to answer this question, I will go to the method of the research, and I will trying to make it very brief. Please, next slide. So you can see here, it is a big project we have done so far in 2 provinces in the country, and you can see that we trying to do a kind of intervention model in 4 communes from the 2 districts in 2 provinces in the country. 1 district is a mountainous district, and 1 district is an urban district. So we're trying to compare the quality of life and also the effectiveness of the model on how to improve the elderly in the country. So we choose 2 control commune and we choose 2 intervention commune. Each commune we have 500 elderly, and then we do a pilot model on healthy aging, and then we trying to compare between pre and post intervention, and also trying to compare between control and also the intervention communes, and to assess the effectiveness of the model, we're trying to give some information on the comparison between the baseline and analyze survey, and between the control and interview, and also we're trying to improve to please how the elderly health has been improved after around 2 years of intervention. But today for the presentation, I will try only focus on the quality of life of the elderly, which is one of the criteria to assess the model so far on healthy aging in Vietnam. Next slide, please. So you can see here that we're trying to do a cross-sectional study, and the setting is 4 communes, 2 communes which are using as a control communes, and 2 communes are using as a intervention communes. And each commune we have 500 elderly elderly per commune, and we use a questionnaire from WHO. We call it the questionnaire is in short is a WHO quality of life, and this is a standardized questionnaire to trying to assess the quality of life elder in the country. And so we do questionnaire to explore the impact factor to quality of life for the elderly, and based on this information we can build and train the intervention model. Actually we do not we have not done the analyze survey, so today I only present the baseline survey on the quality of life of the people in of the elderly in the 4 communes. Please go to slide. And next one, please. So now it's some of the results from the baseline survey, and you can see on the slide here we have assessed the quality of life among 1,900 of elderly in the 2 communes, and you can see here the females have a high rate compared to the male, and you can see the 2 province. The first row is the setting is the 2 different district that we have done our survey. The first one is the urban district. The next one is Kim Bôi is a rural district, and you can see the quality of life between urban and rural area is the characteristic of the between the two province, the 2 district is not very different. It's quite similar comparing with the setting, comparing with the age group, even the ethnic group is quite similar, and also about the religion and education level, it's quite similar between male and female. But compare between the 2 districts, you can see in our setting for the ethnic group we have around 1/3 is the ethnic group, and you know that the ethnic group they are always a vulnerable group for healthcare in Vietnam, and I think in other country also. For the age group we also have around 1/4 is the elderly who are 75 years old or higher, and it is also saying that Vietnam this kind of sampling is quite representative to the elderly in the country, because we now have very high longevity. I mean, the expectation of the of life is very high in Vietnam. For the woman, it is around 76 years old, and for the man, it's around 72. So you can see here with the group around 1/4, more than 75. It is quite representative for the country elderly. So we hopefully this kind of survey quality of life can try to answer that how the current situation of the elderly in the whole country. Next slide, please. Yeah. So this is the how the health situation of the elderly in Vietnam, and you can see here we use a questionnaire from WHO, and the questionnaire of WHO, they had around 8 different dimensions. But here we only present 6 dimensions, because the 2 dimensions, the first one is a religion, and the second one is a quality of mental health. It's very similar to psychological. So we merge it into one. So that's why we have only 6 different dimensions compared to the 8 dimensions of the original version of WHO. And you can see here the physical health is very low in the elderly, with around 46.7%, saying that they have common illness in the last month. So it's quite high, because it means that nearly a half of the elder, they don't feel they have a very good physical health. And that is not our result also. When we compare to the other study, smaller scale and previous study in Vietnam, it also have similar results, saying that about 1/3 to 1/2 of the elderly in the country, they are living under poor physical health, which is really alarming problem. The second one is level of independence. You can see that around a third of the elderly have to base on daily health. They can do the normal daily activity. So around 30% of female and 31.3% of male is not independent in their daily life. So it means that a third of the elderly in the study, they have some difficulties in their daily activity, which is quite easy to understand, because their physical health is not good. It means that they can they have a higher independence on the other, or higher independence on the health system. The psychological, social relation, and the environment is right. So we're not very. I think that is good, because it meaning that the mental health and also the environment in the place that the elderly is living is quite good. The income, you can see that 80% of the male and around 78% of the male and 80% of the female is have an independence on income. It means that around 1/5 of the elderly, they don't have enough income, and they have to rely on the other for their daily expense. So that is the major from the baseline survey, saying that the elderly in Vietnam is not good in physical health, and they have to depend on the other, on their daily activity or on their daily income to to ensure that they have a good life. So based on this, for the next, we will try to do some intervention on we will try to do some intervention for the elderly, because we can see that the elderly is not in a good health status, and then we need to do something. We intend to do that in 2019, but unlucky that we got the COVID-19, and we have to delay our intervention up to now. And we hopefully, when things become normal, we can start our intervention in 2021. And then for the next conference, hopefully I could join and then present how the result of the intervention in the country. So thanks very much for hearing my presentation. And looking forward to seeing your question.
Thank you, Dr. Duong. There is one question for you from Yulis Rima, Indonesia. May I know what program do you provide for the elderly to remain productive without offending them, considering that parents are people who have decrease in performance?
Okay. Yeah. Thanks very much for the question. I think that you are trying to talking about that elderly with a disability or elderly who got difficult in their daily activities. So actually in Vietnam, we don't have a good model for taking care of these elderly actually. But from my experience in the world, I think that for the people with disability, it's very, very important to understand their difficulties one by one. And then we need to give them some of the support using the available resources in the local context. So that is very difficult and that is very important. And then the next thing that we have to trying to give them available equipment based on the local context, based on the current resources we have, and to support them to do some of the exercise for rehabilitate their normal functions. So that is how I experience from the some of the intervention we have in Vietnam, but not in this study. We don't have this model for these people yet.
A question to Dr. Duong. Hi, Dr. Duong. You have an interesting finding on religion, which is surprising. Only 1.3% of the respondents answered yes, and almost all answered no to your question on religion. Could you comment on that?
Yeah, actually, Vietnam is a Buddhism country, as you have heard before. But because Buddhism become one of our culture, so when we are not strictly follow the Buddhism, we only doing some of the Buddhism activity in our home, and at that we call it free religion. But if I have to say that if we classify it as kind of activity for some of the Buddhists, so it could be kind of Buddhist ism the most that our country. But actually, because it's a activity daily culture, so we call it we are free from religion. If one is called a Buddhist in Vietnam, you have to come to some pagoda and you have to perform further and many other activities for as you are a Buddhist. But normally we don't. We only doing some of the some activity to memorize our ancestor in our home. So it's not really Buddhist. So that's why in our country, most of the people now is free from religion. Thank you.
Okay, thank you very much, Dr. Duong. Thank you all speakers for the informative and interesting presentations. We apologize the technical glitches this morning, and thank you for staying on for the rest of the morning. Distinguished guests, ladies and gentlemen, we will be having lunch break for about 1 hour and 15 minutes. The afternoon session will begin at 2 p.m. Malaysia time. Thank you and see you again in the afternoon.